Welcome to Mastering and Guideline in Ultrasound and Echo. Hi everyone. In this very interesting case, I am going to represent many basic knowledge in echo and ultrasound and practical points and tips that I hope it will be useful in your board exam, in the practice, and in clinic. We have a patient, first of all, a 38 years old man that represent in emergency with abdominal pain and nausea that on the EKG, there was evidences of the acute coronary syndrome and echo request and prefer. First, we go step by step and evaluate all those findings and how we approach them and how interpret them. First, as you can see on this here on the plaques, we have one unecho structure and one hyper echo structure here, unecho and hyper echo. First of all, this patient has pericardial effusion, although this area is pericardial effusion, pleural effusion, or what? And second, what is this structure? Second, what these are bands on here at the septum, we have unecho structure or low, very hypoecho or unecho band on the septum and hyperecho on the left ventricle. What is the entity of each of them? And why the basal in this area is severe hypoecho or almost unecho basal segment. What is going on here and here too? And what is your interpretation? All those findings in this area. And the final in this view, based on the plaques, and this is RVOT on the plaques, is a modified view. What is this structure? This hyperecho band that you can see here and here. Is that Swan-Gang catheter or pacemaker lead or impella or artifact or what? What is your logic reasoning for your guess? Here in apical, we get it these clips and images. First of all, in this four-chamber view, a little off axis and the specific view, we can see some structure echogenic at the apex. Just based on the 2D image, can we make sure over 80-90% is that real or artifact or not? What is the logic reasoning for your opinion? On the contrast study, we will get this view and we don't see anything there. So is that artifact or there is something wrong? You have to say why. Because when we do some maneuver, suddenly it show up. And not only on that one, we will see some structure on the right ventricle apex too. If we focus on the apical 4 here, we see the same structure, the same area here too. So what is why we don't have this one? Always we say definity is to completely make it 100% rule out or confirm thrombosis or any intraventricular structure abnormality. On 2D we have it, but on this view we don't have it, but in this view we have it. What is going on and why? And what is the point of this study? my point, there is a specific point that later I'm going to explain about that. Based on that, this R we have three apical 423. Exactly what type of the wall motion abnormality in each of those wall and segment we have. Now let's go to the next one. Now, based on all those clips here, 2D and contrast, what is the entity and diagnosis of this structure at the apex of the right ventricle? Is that thrombosis, papillary muscle, unusual papillary muscle, chorda tendini, artifact, what? And what is your approach and logic to confirm your diagnosis? Here we have for the right ventricular functioning TAPSE and TR. And IVC was dilated, but collapsibility less than 50%. How much will be RVSP, right ventricular systolic pulmonary pressure, based on the echo calculated and based on the number and this finding? The number that we calculate is underestimated, is overestimated, or is almost completely correct. Why? Here we have the histologic evaluation. LA was normal size and other Doppler study we have here. First of all, is that any of those measurement is wrong or not? And second, what type of the diastolic dysfunction we have in this case? Now let's go one by one to all of them.